Yeah.
Please. The countdown. Okay. Good evening, everybody. I'm Dr. Ibrahim Umman. I'm the senior consultant at Apollo Hospitals, Chennai, and the current president of the Heart Failure Association of India. With me is Dr. Hari Krishnan, whose brainchild is this program, and Dr. Chopra, P.K. Chopra, who's the founder, president, and the force behind the organization. So we welcome you all to this year's the virtual heart failure masterclass. This is like directed mostly towards postgraduates and people who have passed out immediately, and also for practicing doctors who are interested in cardiology. So I welcome you all, and then I request Dr. Chopra to say a few words, and if Dr. Hari Krishnan is there, he can say a few words. Then progress into the sessions. Over to you, Dr. Chopra, sir.
Thank you, Abraham. A very warm welcome to everybody, students and teachers alike. These programs have been going on extremely successfully for the past many months, maybe 2 or 3 years. And all of us have learned a lot from these programs. The idea is to bring together the best of Indian faculty, train our students to improve their knowledge, and also to help them pass the examinations. And also we get an invited faculty from Europe or USA or from our country to give a talk. This year we have tied up with Heart Failure Society of America for today's talk. So we keenly look forward to this particular program to learn more. So with that, over to Hari and Arun.
Good evening, ladies and gentlemen. Once again, we are restarting the program of Heart Failure Masterclass. We will have 10 programs every year. So this year we have tied up with Heart Failure Society of America. They will be having 5 lectures in these 10 talks. So today it will be Dr. Anuradha Lala, who is the program director and heart failure research at the Weiner Cardiac Institute. So she will be delivering the talk, and then we will have the case presentation. And after that, Dr. Lala will join towards the end for some questions or any queries regarding her talk. So over to Arun for the details. And once again, welcome to the Heart Failure Masterclass.
Thank you, sir. It's a privilege to have this to start off this year's sessions. As we've started heart failure clinics in 2021, and it's been growing from strength to strength. And without wasting time, we'll have the first talk from Dr. Anuradha Lala. Yeah.
Hi, good morning. My name is Anu Lala, and it's a sincere privilege and honor to be here with you today, albeit virtually, but I will be joining in person for the question and answer portion to speak a little bit about redefining success in our field, really moving from failure to function. These are my relevant disclosures. Of course, you all know our role at the Journal of Cardiac Failure, and we welcome your submissions and your engagement with us. So, my thought process in heart failure on this subject has really evolved tremendously. On the left, you can see myself as an intern here in the middle with Dr. Fuster, who was our attending in the CCU. And over the past 15 plus years, he's always told me to focus on stage A heart failure. And I never knew what that meant. And it's taken me a while to kind of come around and think about that. And this is really going to form the basis of how I hope to convey to you that we should move from failure to function, and really kind of emphasize the importance of prevention throughout the journey of our patients. So again, over the next 12 to 15 minutes, we're going to review briefly what heart failure is, which this audience needs no real review on, but we'll quickly just kind of lay out the background. Then we'll talk about some heart failure epidemiology, particularly as it pertains to the US, risk factors for heart failure, and then this incredible idea of secondary prevention in heart failure, which we never really talk about. We practice, but we don't quite clearly define. And then links and calls to action in terms of linking prevention to heart failure. So I think we all recognize the new universal definition of heart failure nicely laid out exactly what heart failure is, which is that it is a clinical syndrome that is marked by symptoms and or signs of heart failure caused by a structural and or functional abnormality of the myocardium that is corroborated by congestion. And I think that's a really key different point. And that can either be by the conventional demonstration of systemic or pulmonary congestion, or simply put now, elevation of natriuretic peptides. And then in the 2022 AHA-ACC guidelines, the stages were sort of redefined with an emphasis on how much our words matter, where stage A heart failure, like Dr. Fuster used to tell me, is no longer called that, but rather it's called those individuals who are at risk. Stage B previously was called stage B heart failure, and now it's called pre-heart failure. So these are individuals without current or prior symptoms, but with evidence of either structural heart disease, anatomic abnormal cardiac function, or elevated natriuretic peptides or troponin levels. And I think that's an important fact to keep in mind. And then stage C and D remain the same, with the caveat being that stage C patients can enter remission with appropriate lifestyle modifications and guideline-directed medical therapy, or remain with persistent symptoms. And then, of course, we still have our classification by ejection fraction here seen on the right, where heart failure with reduced ejection fraction are those patients with less than 40%. Those patients with mildly reduced are 41 to 49. So we've changed that middle range EF to be mildly reduced to emphasize the spectrum of ejection fraction. And then we have heart failure with preserved ejection fraction over 50%. We also have new nomenclature with respect to those patients who had a low EF that has now improved to more than 40% or by 10 percentage points, and that's called heart failure with improved ejection fraction. Okay, so getting to the topic at hand, what does prevention have to do with heart failure? Well, for starters, our guidelines published in JCF in 2022 made prevention in the top 10 take-homes, where stages of the heart failure stages of heart failure rather were revised to emphasize new terminologies, including those who were at risk and those patients with pre-heart failure, as we just talked about in the preceding slide. And they emphasize the importance of prevention in those groups. But I would argue we should emphasize the importance of prevention across all stages of heart failure. So why is this the case? What is the context here? So these are statistics and data that come from the Heart Failure Society of America stats document, which is published in JCF on an annual basis, most recently in January of 2025, where it's really remarkable. I mean, it's over 6 million individuals in the United States live with heart failure, 26 million globally. And the United States, by 2050, this is projected to almost double to 11.4 million. When you look at it by stages, however, most of these patients fall in the stage A, stage B, those patients who are at risk or those patients with pre-heart failure. And these are a number of observational population-based studies. And I would say that the same is likely true globally. When we look at lifetime risk, it's astronomical. And this, again, from the heart failure stats document, but 1 in 4 individuals is going to develop heart failure. That's remarkable if you think about it. And so the urgency with which we have to address this issue is tremendous. When we look at the etiology as to why this is the case, overwhelmingly, hypertension is a major driver of heart failure incidence, as well as ischemic heart disease. But when you look at hypertension denoted by this light blue here, that is very prominent, especially as we increase in age. And then, of course, there's a variety of other etiologies that are relevant, dependent on the geography, nationality, and cultures, of course, as well. Okay, in terms of the US and the burden, heart failure is one of the most common reasons for hospitalization, over 1 million admissions per year. It's a major cause of morbidity and mortality. When you talk about mortality in the hospital when you're admitted for acute decompensated heart failure, it's remarkable. It's on the order of 4 to 8%. And, we trivialize it because we say, oh, you're here for diuretics and, a tune-up, and then we'll send you home. But we don't recognize that that's a really sentinel event in the patient's life, whereby the mortality is predicted to be 50% at 5 years. This is, in line with many cancers, and yet cancer holds so much more fear in the eyes of our patients than the diagnosis of heart failure. The costs associated are also astronomical. And yet, despite all of the incredible advancements we've seen in therapies, both pharmacologic and device-based, we've seen this disturbing trend showing that mortality over the past decade has actually been on the rise. And we hope to see this trend now reverse once again, but it is kind of concerning because it's not commensurate with the number of advances that have taken place in terms of scientific discovery. So it begs the question, well, why? Is the risk factor profile just building up and worsening such that the incidence of heart failure is only going up? And I would argue that this is a major part of that trend. And so we need to talk about those risk factors. So what are they? I think we're very familiar with the traditional risk factors, but I really like this reframe that the American Heart Association put out, which is very relevant to our South Asian population, of course, globally, which is this cardio-kidney metabolic syndrome. And when we think about it from that perspective, stage 1 is really excess and dysfunctional adipose tissue, where the weight to height ratio is altered. It's more than one half. There's impaired glucose tolerance that then progresses to stage 2, where there's hypertriglyceridemia, hypertension, metabolic syndrome, type 2 diabetes, moderate to high risk CKD or chronic kidney disease. And then it progresses into stage 3, which is subclinical cardiovascular disease and CKM syndrome, ASCVD, subclinical heart failure. So this, stage B, pre-heart failure, ultimately to CKM syndrome, which is coronary disease, heart failure, AFib, stroke, peripheral arterial disease, etc. And when you look at it like this, it's remarkable with respect to the United States population, 90% of US adults are estimated to have stage 2 or higher cardiometabolic health issues. And this affects every major organ system. It's not just the heart, right? It affects our cognitive function. We see steatotic liver disease. We see obstructive sleep apnea, increased risk of cancer, kidney disease. I think it's really tremendous because it's helping us reframe health in the context of the entire body rather than just individual organ systems. Okay, so we know hypertension is a major driver of this syndrome, as well as, of course, heart failure. And so how does this happen? Well, one can argue that hypertension can lead to heart failure either with preserved ejection fraction or a reduced ejection fraction. This is an oversimplified diagram, but you can see that chronic hypertension clearly leads to left ventricular hypertrophy and remodeling, leading to symptomatic heart failure with a preserved ejection fraction, diastolic dysfunction being primary in terms of the hemodynamic compromise. And then with respect to low EF, it may be with or without myocardial infarction that one develops low ejection fraction with extensive remodeling, eccentric LVH, systolic LV dysfunction, and reduced ejection fraction. Now, the primary prevention is so critical because we know that the risk of having cardiovascular events is linearly associated with the degree of systolic blood pressure. And so while the target blood pressure may be uncertain to some degree, really the focus should not be, oh, should I keep it less than 130 or less than 140, but rather BP lowering therapy is beneficial for preventing heart failure incidents in conjunction, of course, with lifestyle interventions. And so when we look at the SPRINT trial, we saw that lowering a systolic blood pressure goal to less than 120 millimeters of mercury reduced incident heart failure by 38% and all-cause mortality by 23% compared to a systolic blood pressure goal of 140. Moving on to diabetes, we know that the relationship here is very, very intimate, and yet it's not very well understood. We know that diabetes is common in heart failure. We know that when diabetes is present, heart failure outcomes are worse. We know that patients with and without diabetes represent distinct populations, and they've been studied separately to show us that. You know, SGLT2 inhibitors and GLP-1 receptor agonists are good examples of that. And then we also know that diabetic cardiomyopathy is a real entity. So how does diabetes lead to heart failure? Well, it's interesting. I love this concept of the fact that we are metabolically flexible organisms, meaning we have metabolic flexibility in terms of how we generate ATP regardless of circumstance. And this metabolic flexibility becomes impaired in diabetes, such that normally we use fatty acids, glycolysis, glucose oxidation, and ketone oxidation. When we have diabetes, we have an increase in fatty acid oxidation, a decrease in glycolysis, a decrease in glucose oxidation, and a decrease in ketone oxidation. Well, what's the significance of this? We see insulin resistance, we see hyperinsulinemia, inflammation, dyslipidemia, endothelial dysfunction, all of which make way for coronary artery disease and ischemic cardiomyopathy. We also see cardiomyocyte hypertrophy, LVH, which leads to diabetic cardiomyopathy with RAS activation, fibrosis, altered calcium handling, altered fatty acid utilization, and autonomic dysfunction. And so ultimately, we see a range of heart failure phenotypes in patients with diabetes, from HFpEF to HFrEF and severe heart failure. What about obesity? This has been making the headlines left and right. We know that obesity is intimately intertwined with heart failure as well, right? It is accompanied once again with insulin resistance, autonomic dysfunction, an increase in catecholamines. Chest wall pressure is increased, leading to intrathoracic pressure increases. We see more obstructive sleep apnea, increases in blood volume, RAS activation, natriuretic peptide modulation, liver steatosis, and widespread inflammation, all of which contribute to the heart failure phenomenon. And then, so those are the traditional risk factors, and we didn't even get to touch on smoking, and this is obviously an abbreviated lecture and is a part of a larger one. But then we have, on top of hypertension, diabetes, obesity being the main ones, we also have sex-specific risk factors in women, where we have higher innate immune profiles, where we see a higher degree of autoimmune diseases like lupus, rheumatoid arthritis, scleroderma. We see breast cancer therapies-based toxicities leading to heart failure, specifically anthracyclines and tyrosine kinase inhibitor. Pregnancy, I think, is not emphasized enough, and this can be globally incorporated to improve the health of women broadly, which is recognizing that pregnancy is a window to a woman's cardiovascular disease risk for her lifetime. So gestational diabetes, gestational hypertension, these are all indicators that this patient may or may not, but has a higher likelihood rather to develop cardiometabolic syndrome later on in life. And then certainly preeclampsia, eclampsia, and peripartum cardiomyopathy are more extreme forms of these manifestations that need to be paid attention to. And then amongst women, we also see acute coronary syndrome without coronary disease. So this is stress-induced cardiomyopathy or Takotsubo's cardiomyopathy. And then we also see spontaneous coronary artery dissection. So that may be apparent, and you may say, okay, great, we know this. We have to prevent heart failure. But how is prevention relevant after heart failure? And I would say all of those factors still need to be maintained. Plus, once the diagnosis of heart failure has been made, we need to keep in mind that these patients have a high number of comorbid conditions. In fact, patients with heart failure with preserved ejection fraction, 50% of them have 4 or more comorbid conditions. This is chronic obstructive pulmonary disease, anemia, diabetes, atrial fibrillation, renal dysfunction, obesity, sleep-disordered breathing. And these comorbid conditions are associated with an increase in mortality. And so we have to address the comorbidities alongside treatment of heart failure. So prevention, secondary prevention rather, becomes exceedingly relevant in our patients with established diagnoses. Okay, what about addressing obesity in heart failure? So this is, again, become an incredibly hot topic in science and discovery broadly. But one phenotype of heart failure with preserved ejection fraction is this obese phenotype, where we can see a lot of epicardial fat and pericardial fat that may impinge RV function, that may lead to more of a restrictive hemodynamic profile, pericardial constraint, among other manifestations. So this has given way to really rigorous study that is ongoing amongst newer agents as well of the incretin-based therapies. So semaglutide being really the more, one of the first kids on the block with respect to treating obesity in heart failure. This comes from the STEP HFpEF programs, in which patients with diabetes and without diabetes were randomized to semaglutide versus placebo. And I'm showing with diabetes to the right here. And this was, the primary endpoints here were feel and function endpoints of changes in KCCQ or quality of life, as well as changes in weight and 6-minute walk distance. And remarkably, semaglutide showed an improvement in quality of life, an improvement in 6-minute walk distance, and a significant reduction in body weight at 52 weeks. As expected, those patients with diabetes experienced less weight loss than those patients without diabetes. This was, later on, the SELECT trial data was published, which took patients with established CVD or at high risk, randomized to semaglutide versus placebo on top of baseline guideline-directed medical therapy. And we saw an early separation of event curves and a reduction in the cumulative cardiovascular event rates with semaglutide. And this included patients with heart failure. So 24% of these patients had an established diagnosis of heart failure, 17% with HFpEF, and the remainder with HFrEF. This begs the question, are all the benefits really related just to weight loss? And what we're seeing is that there's likely more mechanisms that are at play. The extent to which benefit was seen was, yes, it was in proportion to weight loss, but there were also benefits seen regardless of weight loss. So there's additional effects that we're seeing as a result of these medications. Similarly, the SUMMIT trial was presented at AHA in November of 2024, which was an outcomes-based trial, which also showed a significant reduction in cardiovascular mortality and worsening heart failure amongst patients with HFpEF, randomized to tirzepatide versus placebo, class 2 to class 4. And what I like here is also there's a significant emphasis placed on waist to height ratio as opposed to body mass index alone. And I think that that's really important for us to keep in mind in our clinics. But these were obese individuals with a BMI of 38 and a waist to height ratio on average of 0.7, when the normal relationship should be at least less than 0.55. Importantly, I think there's this interesting phenomenon that we need to learn more about, which is maybe these drugs also make the kidneys more receptive to diuretics. And so that's potentially why we saw a reduction in worsening heart failure as dictated by a need for increases in oral diuretics. I think obesity and heart failure, it's complicated to say the least, but certainly addressing it is critical, and we're seeing that now, and we've essentially proven that with a number of trials, and I think other trials that will be forthcoming, not just in the HFpEF population, but also in the heart failure with reduced ejection fraction population. Even amongst the small minority of patients who go on to receive an LVAD or a transplant, we're still working on prevention in these patients. We're preventing or treating obesity, we're treating hypertension, we're treating diabetes, because this is what these patients are ultimately succumbing to. And so prevention is incredibly important even after patients have gone on to receive advanced therapies. You can see on average BMI increases after LVAD, which can pose major complications in terms of driveline infections, transplant eligibility, and otherwise. And so I really like this idea because we call it medical management, but again, the emphasis should be on prevention throughout the patient's journey and lifespan. Similarly, I would say it's even more pronounced in those patients who go on to receive a heart transplant, perhaps a little bit less relevant for our Indian population and colleagues in terms of the population that will actually be affected by this or receiving a heart transplant. But nonetheless, it emphasizes the point that what they end up succumbing to is kidney disease, hypertension, diabetes, really cardio-kidney metabolic syndrome once again. And so prevention is so key. In fact, the guidelines tell us that all patients should be on a statin therapy, that we should be targeting an LDL less than 100. So again, we just carry out these prevention-based guidelines and management throughout the lifespan of our patients, regardless of where they are on the heart failure spectrum. So my time is short. I just want to end with something that I think is critical, which is just emphasizing how critically important emphasis is on prevention throughout. And this is nicely summarized in the Life's Essential 8, or really 9, I would argue, when we include psychological, emotional health. This is plant-forward diet or Mediterranean diet, physical activity, refraining from tobacco, getting adequate sleep, at least 7 to 9 hours, ideal body weight, BMI, lipids being controlled, avoiding hyperglycemia, and keeping a blood pressure that is within range. And this is really the lifestyle 8. And then, of course, psychological health is really important. I think we cannot emphasize enough the role of emotional and spiritual well-being and health in cardiovascular disease prevention and relevant to heart failure, because depression is linked to worse risk factor profile and worse outcomes, and mindfulness, spirituality, and practices are linked to good cardiovascular health, favorable risk profiles, fewer adverse events. I think along these lines, exercise needs to be emphasized more, and I think rehabilitation to that extent needs to be more ubiquitously available to our patients. This has been studied in a variety of scenarios, both HFrEF and HFpEF. This was the HF Action study that showed a significant reduction in cardiovascular death and heart failure hospitalizations amongst those patients who were actually adherent to the therapy. So it works if you use it. Similarly, we're exploring this now. Even in starting rehab in the inpatient setting is not only safe, but effective in improving 6-minute walk distance, improving depression scales, improving quality of life, and improving frailty. Ultimately, no matter what type of doctor you are in cardiology, all roads lead to heart failure, and that's what we're trying to prevent. Whether it's valvular disease, whether it's atherosclerosis, whether it's arrhythmias, ultimately we're all trying to just prevent the end stages, which is heart failure. So I would end with the fact that I think our words matter, and we need to reinvent heart failure and really use the word heart function. Because if we did what we did in heart failure with other subspecialties, we would say things like, I'm going to my lung failure doctor, or I'm going to my kidney failure doctor, or I'm going to my foot failure doctor. But this is not what we do. I think the word failure sets us up for an inaccurate representation of what we do. It's binary. It sets patients up for fear and anxiety and hopelessness and perhaps less engagement. And the branding has not been successful. Nobody wants to introduce themselves as a heart failure doctor. But if we use heart function, it can represent the bigger tent of what we actually do. It allows for the spectrum to be emphasized. It may be a better setup for trust and engagement. And it gives us the opportunity to rebrand with in cardiovascular medicine, not only with our patients, but also amongst our colleagues. So I'd like to end with sharing that heart failure and prevention are inextricably linked. Heart failure is common and deadly. Prevention of heart failure is key with risk factor modification, that prevention after heart failure is vital, and our words matter if we are supposed to move from failure to function. So with that, I think we can be the change that we wish to see in this world, and I thank you so much for your attention. I apologize for running over.
I think we will move to the case presentation. Arun, you can introduce the faculty and the students, please.
So after the wonderful session by Dr. Anulala, we'll go to the case presentation. And it's my privilege to call upon our esteemed examiners, Dr. R.J. Manuran, Dr. Sudhir Kumar, Dr. Ajay Behel, and Dr. Rahiyanathul Misriya from Kottayam Medical College. And the case presentation will be from PJ Chandigarh, Dr. Rahul. You may be ready with your slides, and it's a privilege to call upon Dr. Vivek, Dr. Sri Gopal, Dr. Manjunath from Kottayam Medical College for the discussion. Over to the examiners, and let's have a wonderful discussion.
Thank you, Arun, for the invitation as well as the wonderful setup. The case presentation is from the PJ Chandigarh, if I'm correct.
Yes, sir.
And who is presenting the case?
Dr. Rahul, please turn your video on and be ready with your
Rahul,
presentation.
yeah. Okay, we are. Sudhir, shall we ask them to start the presentation?
Yeah, please, sir.
Okay.
Rihanna.
Dr. Rahul. Okay, Rahul, you can start now. Your time starts now. Rahul, are you there?
Yeah, he's coming, sir.
Okay.
Can you make it full screen, please? Yeah. You can put on your video and come.
Yes.
Yeah, no, it's on.
Am I audible?
Yes.
Yeah, you're audible. Please go.
Yes, sir. Good evening, everyone. I'm Rahul Bundela from PGI Chandigarh. Thank you for providing me opportunity to present case in front of esteemed cardiologists. History. A 54-year-old gentleman working at a managerial post, president of Chandigarh, presented to hospital with chief complaints of swelling of joints of hands, ankles for 5 months, shortness of breath, and swelling of feet since 3.5 months. History of presenting illness. The patient had been in his usual state of health until 5 months when he developed painful swelling of joints of right hand involving hands and wrists and shoulder joints responsive to painkillers. He developed similar symptoms in left hand and ankle joints a few days later. There was no associated joint of deformity and no variation in pain. He also had shortness of breath on exertion starting 3.5 months back. Initially, he noticed shortness of breath while hurrying upstairs, which later progressed to while walking. That is NIHA 2 to 3 in last 2 months. History of a patient has been having history of PND since last 1 month and with no history of orthopnea. Bilateral swelling of patient has been experiencing bilateral swelling of lower limbs since last 3 months, insidious onset, gradually progressive. There is no history of chest pain, syncope, fear with cough, decreased urine output, frothing of urine, or abdominal distension. No history of melena and jaundice or any rash, malar rash. Past history. Patient is known case of hypertension since last 15 years or olmesartan. Known case of diabetes mellitus, well controlled on oral hypoglycemics since last 10 years with no history of any surgical and medical illnesses. Patient is known case.
Go on.
Okay. Treatment history for joint pain, the patient was in follow-up of rheumatology clinic since last 5 months, was on NSAIDs and methotrexate for which symptoms were partially resolved. Family and personal history, CAD and hypertension in his father at 55 years of age and hypertension in his mother. No history of smoking, alcohol, and is vegetarian. Summary, 54-year-old gentleman with known history of diabetic and hypertensive with history of bilateral symmetrical arthritis with worsening of dyspnea, which progressed to NYHA second to third in 2 months, accompanied with pedal edema, features suggesting simultaneous onset of left heart failure and right heart failure. Shall I continue to
start.
examine?
I think the postgraduate from Kottayam has to discuss. Am I right, sir?
Yeah, I think so. Okay, we'll allow a few comments about the story. I thought arthritic symptoms, this patient had arthritic symptoms. A little more details about the arthritis would have been worthwhile, because we have to be certain whether this arthritis has got any connection with the present heart failure or the present symptom of cardiac decompensation. So a little more details about the heart failure would have been about the including the treatment, more details about the treatment, and whether any investigations has been done for the joint symptoms, because that can also come part of the information to discuss about the cardiac condition. Was any investigations done on this patient, like ASO, rheumatoid, RF factor, NA factor, all those things? Do you have any information?
Yes, RA and CCP were negative for this patient. They were treating on lines of seronegative rheumatoid arthritis.
Okay, right. Okay.
Shall we ask the postgraduates to ask doubts and clarify?
Yes, we'll do that.
And let them interrogate, sir. Otherwise, sir,
Okay, we can do that. Yeah, we'll allow them. Ask the medicine postgraduates from Kottayam Medical College to
cardiology postgraduates.
Cardiology postgraduates to interact with the presenter and see how much information we can get from the story.
I would like to thank the esteemed panel for the opportunity. So coming to the case discussion here, patient is a 54-year-old gentleman who is a known
Before that, Sri, would you like to clarify certain things, or you are comfortable with the history provided? That's the first step. Am I right, sir?
Yes, sir.
Yeah. No, first of all, you have to, if you want any clarification, yes, you can do that. If you think that there is no need of a clarification, history everywhere, everything is clear, then you can straight go to the discussion. So first of all,
yes, sir. We would like to know whether the joint pain involvement, was there any deformity associated with the joint for?
There was
no deformity.
So that is definitely. I think he mentioned that, if I remember correct. He said there was no deformity.
He said no deformity.
No deformity.
Yeah, he said that.
And about the pedal edema, sir, whether it was a progressive pedal edema, and what about the diurnal variation of the pedal edema? That also would have been a bit helpful.
It was insidious and progressive pedal edema.
Pedal edema. What about the diurnal variation, or
notice more on the end of the day?
End of the day it was more.
Yeah.
Okay.
What do you think? What do you think about the cause of that edema, Sri Gopal? What do you think about the cause of this edema? Because he concluded that it is right heart failure. You are happy, or any other condition which can produce edema in this case?
Patient is having hypertension, diabetes.
He was on non-steroidal anti-inflammatory drugs. NSAIDs. He was on NSAIDs. You should ask what was the NSAIDs, what is the duration of this thing, because what he has documented now is pulmonary and systemic congestion.
Yes, sir.
Okay. We don't know whether he has a heart disease or not.
Yes, sir.
Okay. So that's an important issue here. Okay, fine, sir.
Yes, I think go ahead. Let him. See, one thing is clear. See, about the left-sided disease, Sri Gopal. What about the left-sided disease? Obviously, it is very clear because
patient of PND, so which is suggestive of left heart disease.
So I was also wondering, how did the presenter conclude that there is associated right heart failure also? So that is still we have to keep in mind whether the right heart failure is there or not. But left heart failure is much more clear.
Yes, sir.
Okay.
Why is stress to us? We get large number of cases of heart failure resistant to treatment because They have so many other drugs in the talk which we heard. So many other things beyond the heart which may be contributing to heart failure. Excess fluid intake, non-steroidal drugs. We don't know whether he was on steroids. All those things we have to look into. Okay, fine. Sir.
Okay, go ahead, sir. Sri Gopal, can you just frame how you are going to approach this case?
Sir, initially the patient, like we can discuss the symptom and then discuss the etiological factors associated.
Okay.
Here, first the symptom here is joint pain. Since the patient is a known case of seronegative rheumatoid arthritis, I would like to attribute the joint pain to that symptom, sir. Like cardiac causes of joint pain usually can be rheumatic fever or post-streptococcal rheumatoid arthritis, rheumatic reactive arthritis. But given the age and absence of the history suggestive of rheumatic fever and presence of history of known case of rheumatoid arthritis, I would like to attribute the joint symptoms to systemic disorder rather than a cardiac per se cardiac involvement.
You want to
Yes,
you want to
short story.
Sorry, sir. Go ahead, sir. Go ahead, sir. Sir, please.
Short story. And this patient, according to story, over a period of 1.5 months, patient went into florid left heart failure. So what is the involvement which can give rise to such florid heart failure?
Myocardial involvement.
Basically, patient is having biventricular
dysfunction is there in this patient. Rapid onset of cardiac symptoms in a short span of time. Maybe myocardial involvement can occur, happen in this case.
Do you think that of course it's far-fetched? Do you think that this could be infective endocarditis?
Yes, actually, no history of any fever, less chance. No history of any prolonged fever. Also, no history of any regurgitation, lesions, or palpitations. Embolic episodes or no other symptoms suggestive of infection.
No, because when there is a very unusual case is being presented, I think you have to think of all possibilities. So I was just thinking whether it could be something like, because some of the patients with infective endocarditis can have a very odd presentation. The first presentation may be sometimes an embolic episode. Another presentation may be a joint involvement. Of course, bilateral symmetrical joint involvement is with an oddity. But I would like to think of a very short history when the patient has gone in for significant heart failure, definitely left heart failure with paroxysmal nocturnal dyspnea. And we are doubting whether there is associated right heart failure also.
Yes.
Basically, I think my approach will be, there are two components in this history. One is the cardiac, second is the joint. Are these separate or they are associated? That's the way you have to look into.
Yes,
The cardiac, I think you should not say biventricular failure. You cannot be that specific. You can say there is definitely a recent onset progressive severe pulmonary venous hypertension because the patient has a classical paroxysmal nocturnal dyspnea, which is cardiac asthma. Regarding the right heart, we are just debating whether it is a systemic venous congestion or is it non-cardiac contribution to the edema. Okay,
Yes.
these two things we are discussing. So you should not say biventricular failure because pulmonary congestion can occur without ventricular failure. You know the conditions. Okay, so it is better take these two things separately. If I am the student, I will put it like this. Sir, this patient has rapidly progressive severe pulmonary venous hypertension, indicating a left heart problem. Second, the edema could be systemic venous congestion or it could be other factors. Then you have to discuss the joint symptom. Postgraduates in cardiology should also discuss polyarthritis. Polyarthritis at this age group. The only problem in this case is these two occurred simultaneously, or the arthritis immediately followed by decompensation. So you cannot get away from that. That is my approach. Because if it was an arthritis which is an innocent bystander or unrelated, here the whole thing started as polyarthritis involving the major joints, followed by or along with that the patient is developing heart failure. So you cannot dissociate that, at least at the initial aspect. So we have to go back into the history. whether he can recollect the history of any polyarthritis in childhood. Okay, that you have to keep in mind, because the things which, because he has said the rheumatoid factor, really everything is negative, but you didn't ask. Was he evaluated for ASO titer, ESR, all those things? Was there an evidence of active inflammatory CRP, all those things? So you should have asked that question to Dr. Rahul. Well, he concentrated only on rheumatoid and all those type of arthritis. So acute onset of acute arthritis at this age group in a male. What are the possibilities? There are very limited possibilities. And this patient has developed cardiac decompensation. As Sir said, that is infected endocarditis, or maybe arthritis at the old age is predominant in rheumatic fever. So we don't know whether the patient had rheumatic fever in the past, because he is now 53 years. So whether he is likely to recollect the events which have occurred 40 years back, we don't know. So we have to ask whether about his schooling, whether he had school break because of some symptom. We are less likely to get that data. Second, you should have asked questions on that arthritis before trying to correlate. Whether the arthritis, get some idea. So I'd be interested in getting information about the arthritis and the investigation he had been done to see whether this can be connected or not. Sir.
Yeah, I also have got some thought process that whether is arthritis, which is described initially, is only an independent bystander or a silent bystander, and whether the patient is having some other setup which has resulted in heart failure. You see, he is a diabetic and a hypertensive. Whether that patient has developed into a diabetic cardiomyopathy, and that is the reason for the development of significant heart failure. Especially the left heart failure is more obvious, right heart failure doubtful. And also sometimes these patients can have silent symptoms, silent coronary disease, and that can be the reason for heart failure. So the keeping the arthritis as an important reason which should be linked with heart failure. But I would like to think whether the whole problem is secondary to the original disease that the patient is having, diabetes along with the systemic hypertension. So we have to keep our mind open, because this is not a very straightforward case. Obviously, the straightforward cases will not be presented here. So there should be something which is strange in this case. So we have to keep our mind open. That's what I think. In addition to the arthritic problem, whether the whole problem is secondary to the pre-existing disease process also should be kept in mind. What do you think about Sri Gopal? Do you think that this could be just a diabetes and hypertension related heart failure?
Yes, sir, it's possible. You have to keep in mind this as a DD.
Now, basically, you have to say the left atrial hypertension is due to with the normal left ventricular function or impaired left ventricular function. If it is with impaired left ventricular function, is it diastolic heart failure with preserved ejection fraction, or heart failure with reduced ejection fraction? That is why you have to go ahead with the discussion of this case. If it is with the left ventricular failure because diabetic, hypertensive, coming with recent onset heart failure, so one of the possibility is a heart failure with preserved ejection fraction, acute decompensation related to development of atrial fibrillation. So you should have asked, what are the factors which precipitate heart failure? As Sir said, is there a background disease that is patient that, as in the previous disease, heart failure at risk, that is stage A or stage B, where the decompensation occurred because of something else? Or is it a de novo heart disease? Okay, that is the way you have to approach this case. Is it a pre-existing problem which has been well compensated, maybe preserved ejection fraction or reduced ejection fraction or mildly reduced ejection fraction, or it could be a stage A or stage B heart failure, and the problem has occurred because of something else, because the patient developed a arthritis. When there is arthritis, a lot of immunological inflammatory changes are occurring, which can produce decompensation. So I think we can extend the discussion to a great extent beyond our monotonous discussion of valvular heart disease, all those things. That is what we expect from the postgraduate students. Where a monotonous discussion of left heart failure, valvular heart disease, ischemic heart disease, myocardial disease, like that. Here you have to see, as Sir said, he is at risk. You have stage A definitely because he's hypertension, he is having a diabetes, so stage B, he is going for stage B. So stage B going for stage C. That is the issue here. Why I'm bringing that discussion is we had to talk on that. Just now
Yes.
we had to talk on stage A, B, C. So it could have been that he has been in stage A, B and decompensated stage C. Why it decompensated? Is it a cardiac thing? Uncontrolled diabetes, excess this NSAIDs? NSAIDs in a patient with stage B will go in for stage C. So what I expect from both of you is that type of discussion rather than the usual monotonous. Because as sir said, this is a little difficult case. At least to begin with, it's a difficult case. Sir, we have Bahal sir also, Rayanat also.
They can give their comment. Just one more point I want to bring in is that when you are discussing this case, he had some arthritic problem. He was treated for that. Is the treatment precipitated this new heart failure? Patient may be having some degree of cardiac involvement secondary to long-standing hypertension and as well as diabetes, as Sudhama rightly pointed out. This combination can have a diastolic dysfunction and some fluid overloading and actually tilted the balance, and the patient is presenting with features of pulmonary congestion, and probably we are not very certain whether there is some degree of systemic congestion also. So I think 2-3 points which are to be kept in mind, whether there is a common situation where the arthritis and the cardiac involvement occurred because of the same problem. 2, the patient is a known case of diabetes, hypertension, whether that has made a stage A, stage B heart failure or cardiac involvement, and this was further aggravated by the disease process or by the treatment the patient has received. And 3, whether the whole thing is independent of these 2 problems. Like something like strange problems like infective endocarditis, which can acutely precipitate heart failure. Anant, do you want to make any comments?
Sir, am I audible?
Yeah, you're audible.
No, muted.
Sir, here is a patient with a recent onset left heart failure preceded by a symmetric, almost simultaneous polyarthritis. So it could be joint involvement with myocardial involvement. So rheumatoid arthritis, pericardial involvement and accelerated atherosclerosis as a part of treatment is usually common. As a myocarditis is less common in rheumatoid arthritis. Another possibility is simultaneous involvement of joint and heart, and possibility rare, even though it's a sarcoidosis, one possibility. Can present as polyarthritis and around this age group with heart involvement.
Okay, sarcoidosis, yeah.
Excellent.
That's a good possibility. But I think sarcoidosis very often will have arrhythmias more frequently.
Yes, sir. Arrhythmias are
That
more
is the only
common.
thing.
But
More common. They can have heart block, they can have ventricular arrhythmias. Those are the usual, more common presentation than presenting as a straightforward left heart failure. That is the only point.
I will ask Dr. Rahul, what is your opinion or comment about those 2 things? The rheumatoid arthritis and sarcoid. I think that's a way you have to think. What are your points in favor, against, or do you agree with that? That is where the discussion goes, because this is not examination. Rahul,
Also,
rheumatoid.
in these difficult cases, we have to keep our mind open so that all possibilities should be brought into discussion.
Rahul, do you think rheumatoid? What do you know about rheumatoid? That's the way in the examination also we ask rheumatoid and heart. What is the
cardiac what is the cardiac involvement in rheumatoid arthritis?
What is the natural history? When does this occur? That is important. Do you think it is rheumatoid? No, I'm not contradicting, but that's a stimulus for you to discuss. Rheumatoid. Because that question will come, rheumatoid.
Rheumatoid usually affects the large joints, small joints, or both?
Small joints. Small joints.
What are the different cardiac manifestations of rheumatoid arthritis, rheumatoid cardiac involvement?
rheumatoid in rheumatoid arthritis, there is exacerbated coronary artery atherosclerosis. It can also affect
Carditis.
Can also
Okay.
affect
Associations are usual associations are pericarditis, pericardial effusion, or myocarditis. And
What is the temporal
myocarditis.
lesion? When does this occur? The cardiac involvement in rheumatoid arthritis.
during the
Suppose I
inflammatory.
develop rheumatoid arthritis now. Is it immediate?
no, sir.
No,
It is
late
relatively
stage.
late. Except when there is exacerbations, you can have an acute thing. So you have to think about the acute inflammatory phenomenon occurring with the active phase and the chronic involvement. So chronic involvement is a chronic progressive involvement where can occur. So rheumatoid, the cardiac involvement is relatively late. So this patient did not have any joint symptoms earlier. The major joints were affected. It was not the smaller joints. Okay, morning stiffness, those things he has not mentioned. So clinically, even though that has to be discussed, that is the way we discuss. Now, when does the cardiac involvement occur? I'm not debating or contradicting Mr. Ria's comment, but there is a stimulus for us to discuss another aspect. There is the temporal lesion, the pattern of involvement, what one person has said, the atherosclerosis, hypertension, all those things, and the other team says about the inflammatory thing. So what is its relation with the stage of the disease? During exacerbations, a chronic rheumatoid. During the acute initial phase, cardiac involvement is relatively less common or very uncommon. In recurrences, when they relapse, sorry.
Shall we continue with the examination because there was already warning has come that there is a time restraint.
Okay, sir. Last, my point is, would you consider rheumatic fever reactivation with rheumatic valvular disease, carditis? That
Yes.
is my one of the things. Pardon?
Sir, it is a like remote possibility, sir. But given the age and there is no previous history of rheumatic fever, and also the duration of joint pain and the symptoms is not very.
Okay, agreed. Not I am not. I will not agree because we are dealing with an odd case.
Yes.
We don't have the diagnosis. The commonest disease which we know with joint pains and heart disease is rheumatic. Okay, go ahead, sir.
And also,
Findings.
as a romantic, of course, the strange point is that as the age advances, with more and more joint is involved, and the cardiac involvement is usually less frequent. So, and also the joint involvement pattern is very atypical for adult rheumatic fever. Something known as Jacquard's arthropathy is described for acute rheumatic fever involvement of the joints. So there is nothing for us to be certain that or think about rheumatic. And also this patient has got a seroreactive rheumatic rheumatoid arthritis. That is the diagnosis of the rheumatologist, I think.
It is a seronegative arthritis.
Seronegative arthritis, yes.
Mm-hmm.
Let us go to the physical findings then.
Findings.
Rahul.
General examination. Patient was conscious and oriented to time, place, and person. Height was 176 centimeter. Weight was 68 kgs. No pallor, icterus, clubbing, cyanosis, endinopathy, or noted. Pedal edema was pitting edema extending till the knee. Pulses 70 per minute, regular in rhythm, normal volume. No radioradial radiofemoral delay. All peripheral pulses were palpable. Vessel wall thickness is normal. Blood pressure in right brachial artery in supine position was 146/84 and while standing 134/8. So there was respiratory rate was 20 per minute, thoraco-abdominal type. SpO2 98%. Patient was febrile or afebrile on examination. JVP was elevated 10 centimeter from sternal angle. A wave and V wave was seen. Rapid Y descent was noticeable. Kussmaul sign was present. Shall I continue,
A
sir?
and B wave seen, both A and V seen, normal or abnormal? Because you are
normal,
making
sir.
a sharp Y descent. I would like to know what is the V wave like. Is it A and B equal with a sharp Y descent? Or V wave prominence with a sharp Y descent? That is important. Go ahead. Go ahead. Next.
No, can the student give an interpretation of these JEP findings? It is elevated up to 10 centimeters, both A and V prominent, sudden wide descent. What are the conditions which you can exclude? What are the conditions you should suspect? Do you think this indicates right heart failure or no right heart failure? Is it just a volume overload or the right heart is failing? Rapid wide descent, what does that mean? Does it indicate that normal diastolic function of the RV?
That means the RA inflow or the RV myocardium, RV inflow is normal or the RV myocardium is having some disease.
Rapid wide descent indicates very simple question. Don't make the answer very complicated. That means there is no obstruction.
Yeah, there's a
Secondly, there are few
diastolic. Yeah. Yes, Dharma.
Yes, sir.
No, I was just thinking that he should have said that the diastolic function seems to be preserved. RV diastolic function most likely is reasonably preserved because there is a good wide descent. What does the A waves mean? You have said that the JVP is elevated 10 centimeters. I would presume that A wave also is around about that much. So what should be the cause for A wave? A wave is prominent.
No, he said A and B wave seen. He did not say the wave pattern, whether it is normal or abnormal. Regarding the Y descent, my approach would be slightly different. I would look at the AV. If there is a prominent V wave with sharp Y descent, I go for tricuspid regurgitation. If the A and B are normal and sharp Y descent because he has said, because it implies that it is more than normal. Sharp Y descent, I go for constrict pericarditis, even though there are odd points. That is the answer which I want. When there is a sharp Y descent, as sir said, the diastolic function is okay, it is filling well. But sharp, that's a normal. It's more, when you say sharp, rapid Y descent, that means there is an abnormality which he has highlighted. So look at the V wave. V wave prominent sharp Y descent is tricuspid regurgitation. A equals V with sharp Y descent is constrict pericarditis. And sharp Y descent excludes RV inflow obstruction. This is the answer which I want. Was there some clue in the previous blood pressure? You think it is okay? Anybody? The student panel? Because we have to analyze step by step because this is an unusual case. What is the blood pressure like?
130,
146, 146 per 84.
Pulse pressure.
The pulse pressure of 62 millimeters of mercury. And it is only 54. So that also you have to keep in mind. Okay, you have to keep in mind because it's a hypertensive. It's a hypertensive, fine, but you have to keep in mind whether the blood pressure is controlled to optimal level. Okay, that also you have to keep in mind. Next, sir.
I'm a bit confused about the JVP findings. A wave, V waves are seen. I would presume that there must be at least 10. When you say about the JVP elevated 10 centimeters, I would presume that this is the mean JVP elevation. And A and V waves are usually about 3 to 4 centimeters above the mean jugular venous pressure. Second, there is a rapid wide descent that indicate that the RV diastolic function is reasonably preserved. So what is the reason for a reasonably prominent A wave? And you also said Kussmaul sign is present. So how will you explain all these findings? How will? Just want to know your explanation. So what are the conditions in which you can get a prominent A wave? Because the height of the JEP is 10 centimeters above the sternal angle, obviously.
As a postgraduate, I think now don't say from the sternal angle. Okay. Definitely cardiology postgraduates, it should be from the root of the clavicle in sitting bone. There is a standard recommendation now for cardiology postgraduates at least. Okay. Second, you said A wave and V wave seen. That time we're not happy. You have to say that sir is asking that question. Is it normal or abnormal?
So normal.
So A wave and V, pardon? Normal.
Normal.
So it's A waves and neither A wave nor V wave is prominent. Only there is a stagnation blood column resulting in elevation of the JVP. Obviously meaning that right atrial pressure is significantly elevated. Is that right?
Yes, sir.
So there is no obvious prominent A wave or prominent V wave. Both are can be explained by the basic JVP elevation, which is due to stagnation of blood or some constrictive process, whatever may be the reason, which has resulted in a uniform elevation of the jugular venous pressure. Is that right? That's your interpretation?
Yes, sir. Yes, sir.
Okay. Right.
JVP,
Okay.
you should be careful. JVP, you will be grilled on JVP. Then what you have to say is this is not a usual thing. You cannot say that. If it is a normal A wave, normal B wave, and a sharp Y descent, very unusual.
That's a very
Or
bit
you could have
uncommon.
said A wave and V wave normal, descents are normal. You have highlighted a sharp Y descent. So you should look back. What are the causes of sharp Y descent and what are there any corroborating findings? Okay, go ahead.
Now, what is the most important reason we think about when there is a rapid Y descent?
So rapid Y descent is seen in restrictive cardiomyopathy, constrictive cardiomyopathy.
What is restrictive constrictive cardiomyopathy? What is that?
You mean constrictive pericarditis?
Constrictive
Yes.
pericarditis. Yes.
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 But the
See,
commonest is the commonest is tricuspid regurgitation.
Yes.
Tricuspid regurgitation.
Yeah.
Yes, yes.
For rapid Y descent, you require only two criteria. One, there should be an elevated pressure at the time when the tricuspid valve is opening, which can happen when there is a prominent V wave. And second, there should be a receptive right ventricle. These are only two things which are required. If these two things are there, you can get a very prominent Y descent. So, and one important condition, of course, is constrictive pericarditis, where the pressure in the right atrium is significantly elevated, and the right ventricle is normal, and the blood can flow rapidly into the right ventricle. Also, there can be a very significant rapid Y descent in a patient with constrictive pericarditis. Okay, so go ahead.
Sir, I don't know whether I'm exceeding the discussion. At this point, with the history, considering these things, what do you think the possibility they have Kottayam group? We will not go to that because at each step we have some differential diagnosis because we have to look for these things. So sharp Y descent, we know it is tricuspid regurgitation, constrictive pericarditis, restrictive cardiomyopathy. Can you say that this is less likely? Which is less likely? Forget about A and V wave because I'm not happy with A and V seen. What about constrictive pericarditis? Because he is trying to highlight sharp Y descent with Kussmaul sign. Because we don't talk about Kussmaul sign.
It mainly presents with a distension right heart symptoms in the history.
So here the left heart failure symptom is dominating. The patient has pulmonary edema. That is not usual with constrictive pericarditis, though rarely it can occur. Because you look at this, he is pointing to either constrictive pericarditis or restrictive because he has highlighted Y descent and Kussmaul sign. But seldom we discuss about Kussmaul sign in other situations. Okay.
Yes.
Okay, fine. Go ahead.
Rahul, why is it that the PND is very uncommon in constrictive pericarditis? Reason? What is the reason? Because the right atrial left atrial pressures can be significantly elevated. It can be sometimes even mean pressure can be 25 or 30. And why the patient is not having PND?
There is usually dissociation of intrathoracic and intraperitoneal pressures.
So what?
It's not it's not transmitted to the pulmonary side. Actually, there is a dissociation between intrathoracic and intraperitoneal pressures. So the PND
No, that's not the reason. In which in a patient with significant right heart failure, can there be a paroxysmal dyspnea?
The LV will be underfilled, sir.
No,
underfilled.
No, sir. Right heart will usually we can get orthopnea, but PND is not common with the right heart.
Yes, the patient can have orthopnea. The patient can have orthopnea. Patient with constrictive pericarditis can have orthopnea, but cannot have PND. Give the explanation.
Many causes are there. Like my heart acts as a syncytial effect. Then also my pericardial constraint. coronary sinus turgor.
Very difficult question. Be careful when you are answering on unfamiliar questions. Okay. Now, basically, in constrictive pericarditis, this question may come. One volume change cannot happen because just like Valsalva, all those things, it is an overfilled. The right ventricle volume cannot change much, even if all the other factors are coming. There is no myocardial contribution to these things. The volume change cannot happen because of the constriction in this case. Second, right heart failure, there is less likely to develop pulmonary edema or PND. The question is, can you explain that in constrictive pericarditis? Diagnosis is constrictive pericarditis, it's a pericardial disease, chronic pericardial disease. And they are having predominant left heart symptoms or severe left heart symptoms. Yes, Rahul?
So
You can
just
have
a
localized
minute.
constriction, asymmetric constriction, annular group can get involved. Annular group can involve, and you can have certain diseases where you can have pericardium as well as valve involvement occurs. Okay, but asymmetric or localized focal pericarditis or asymmetric pericarditis, annular groove, there can be constriction. That can produce severe left heart symptoms also. Okay, sir.
But usually, yeah, of course, one important point about development of paroxysmal nocturnal dyspnea is that there should be a change in the volume of blood which is being rejected out of the right ventricle. And in a patient with constrictive pericarditis, there cannot be a change in the volume. So the right ventricle, even when it is trying to have a venous return, when there is a more fluid reabsorption, and if the fluid is being returned to right ventricle, to the right side of the heart, the right atrium and the right ventricle will not be able to accept this blood, and that extra volume of blood cannot be ejected onto the left side. So patients with constrictive pericarditis, as you rightly said, can have orthopnea, but they cannot have paroxysmal nocturnal dyspnea. So that's one point. Second point, Sudhkumar has pointed out whether it can be a unusual situation where there can be constriction of the certain regions, especially if there is a left side constriction or if there is a constriction in the region of the left atrioventricular groove. But the only thing is that it's a short history. History is too short for the patient to develop that type of a problem over a short period. So I would think that would be a stray. Of course, you can discuss the possibility, but I would think that it would be quite low in the list.
That's only stimulating discussion, sir. Stimulating discussion. And
Okay.
what sir, both of us said, volume rise. So the large volume cannot be handled by the right one. That's why the Kussmaul sign occurs.
Yeah,
so
that is why
the
there is
volume cannot
Kussmaul
be pushed to the ventricle, to the left heart. So they are less likely to develop pulmonary edema, all those things. That's why left heart symptoms are less impressive. Okay, sir.
Go ahead, let them go ahead. Otherwise, we will not be able to finish. Okay, go ahead. Further findings. Rahul.
Yes, sir. Systemic examination.
I think the Kottayam students also should take part in the discussion. Suddenly, Sri Gopalan has become suddenly silent. I think you should form part of the discussion. And if you have any point which you think in the discussion is not very easy to digest for you, then you should bring it up so that we can discuss that point also. So this should be a learning process. So
History also.
Yes.
Okay.
Okay, go ahead.
Yes, sir. Systemic examination, inspection, chest wall appears symmetrical, trachea is midline, apical impulse seen in left fifth intercostal space in the mid-clavicular line, no visible pulsations seen elsewhere over the chest or epigastrium, no visible scars, sinuses, no precordial bulge. On palpation, trachea is midline, apex beat palpable fifth intercostal space in mid-clavicular line, apex beat is heaving in nature, localized LV type, parasternal heave grade second, no palpable pulsations, thrill. Heart sound, S1 was normal, S2 normal intensity and normal split. LV, S3, S4 are present. No opening snap or ejection click, no murmur heard. Other examination, respiratory system, normal vesicular sounds heard in all areas. CNS, no focal deficit. Abdominal uniformly distended. Liver palpable 2 cm below right costal margin. Non-tender, no shifting dullness.
Sorry, previous we had a third sound and fourth sound. Previous
both
right?
Yeah,
we
both
have,
S3 and S4.
LV, S3 and S4. Okay.
So can you explain S3 and S4? And in a patient who has got a perfectly normal heart rate, everything normal. suddenly having an S3 and S4? Can you give the explanation? Second, first S1 is normal, S2 normal intensity, normally split. The heart is normal in size, almost normal in size. Of course, it's a LV type of apex. And also the heart rate is not normal. And then you are saying S3 and S4. What is your explanation?
So
what are the causes of S3? What are the causes of S4? What are the conditions in which you get S3? 4 or 5 conditions.
So both are diastolic sounds. S3 you get in heart failure.
Okay. Usually it is a link to heart failure. Okay. Yes.
Yes.
I'm not happy because
what are the
heart
conditions
failure is a
in
very broad term. Heart failure is a very broad term for the postgraduate.
what
Because
are the
S4
conditions?
also it is diastolic heart failure. Okay, fine, go ahead.
S4 is more suggestive of diastolic heart failure. S3 you get in left heart failure, more suggestive of left heart failure.
Not necessary. S3 you get in CCP, you get in RCM.
In restricted cardiomyopathy, what do you get? You get an S3 or S4?
RCM S4.
S3, sir.
S3 is more frequently S3 is audible, and S4 is not a common phenomenon in a patient with a restrictive cardiomyopathy. Now, so you said immediately when you said when there is an S4, it means the patient is in diastolic heart failure. Every patient with the S4, you think it's diastolic heart failure?
No, sir.
Then patients coming with ischemic heart disease. Ischemia can give rise very often. The commonest cause for allowed S4 is an hypertensive patient with ischemia can have allowed S4. So immediately you think that this patient is in right heart failure. Sorry, diastolic heart failure. The atrium is contracting differently, but that does not immediately mean that there is a. What is the definition of heart failure? Define heart failure. Rahul, define heart failure.
So depending on EF, it can be preserved ejection fraction or mid ejection fraction.
No, define heart failure. Define heart failure.
Not the types of heart failure. What is heart failure? Define heart failure.
Define heart failure.
Heart function is compromised, not leading to end organ dysfunction.
Is it heart failure?
Under stress.
Is it heart failure? Sri Gopal, can you define heart?
Signs and
Go to the content.
signs and symptoms heart failure secondary to functional or structural abnormalities and corroborated by elevated natriuretic peptides or cardiogenic pulmonary or systemic congestion.
I think you can define heart failure simply. Heart failure is defined as a condition where the heart is not able to pump adequate quantity of blood to meet the metabolic demands of the body, or can do so only at an elevated filling pressure. The first part indicates the systolic heart failure, and the second part indicates you can say a diastolic part. So it is the inability of the heart to pump blood to meet the metabolic demands of the body. It is not reduction in pumping of the blood. For example, patients with thyrotoxicosis, patients with anemia, beriberi, can have very significantly elevated cardiac output, cardiac performance, but the patient is still in heart failure. That is because the heart is not able to meet the metabolic demands. In thyrotoxicosis, there is a high metabolic demand, heart is unable to do it. So it is the inability of the heart to meet the metabolic demands of the body, or can pump adequate quantity of blood to meet the metabolic demands of the body, or can do so only at an elevated. So by just hearing an S4, you are immediately diagnosing that the patient is in diastolic heart failure.
Sri Gopal et al., you could have started the answer like this. The universal definition of heart failure, what you have said. Then the examiner will ask you what is it. Then you have to say, because you can defend your answer also. Because we have heard the talk on universal definition. But what sir said is the basic classification. So you should know both. So you should start with the basic definition and the universal definite. Then you are safe. Okay.
Yes.
Yes, sir.
Okay, and this patient is having
Now-
both S3 and S4, so he's having systolic as well as what type of heart failure this patient is having? S3 and S4. What type of a heart failure, according to you, this patient is having? Third heart sound indicate. See, that's why I asked a question. Whenever you hear a sound, you should analyze what may be the reason for that sound. So according to me, third heart sound means what are the conditions in which you get a third heart sound. So then you have to fix one of them. What are the conditions in which you get a third heart sound? In constrictive pericarditis,
Rapid filling, conditions the rapid filling of LV, heart failure, severe MR.
Okay, I would put this way. Of course, third heart sound can be normal up to what age? Young adults up to age of 20 or 25. Sometimes third heart sound can be normal. Two, in patients associated with heart failure, there can be, especially systolic heart failure, there can be a third heart sound. Patients with volume overload, especially initial large volume of blood coming into the left ventricle, like mitral regurgitation, VSD, PDA, ruptured sinus valsalva can have a third heart sound. And sometimes in patients with here with something like mitral regurgitation, where when the blood, during systolic phase, the blood goes into the aneurysm, and during diastolic phase, it comes back to the left ventricle. Rapid flow of blood come into the left ventricle, and these patients, even without heart failure, there can be sometimes there can be a third heart sound because of the large volume of blood suddenly coming to the left ventricle. So you have to think what will be the, and of course, in constrictive pericarditis, there is something which can be very similar to third heart sound, which is known as the
pericardial knock.
Pericardial knock. So according to you, you examine the patient. Which one fits in this situation?
Shall I intervene in? Shall I contribute, sir?
Yeah, please.
One, my approach will be this question, because LBS3 causes you should answer, because there is no need for teaching, because you should answer all those things. 4 also you should answer. But the thing is how to interpret this background. Here the point which you have found in this case, he has a heaving apex beat. So the heaving apex beat in a hypertensive patient who has gone in for heart failure. Heaving apex beat, there is definitely the diastolic part, and you can easily explain the fourth heart sound. Then the third sound indicates in such a situation, because obviously there is no hyperdynamic circulation, there is no volume overload, because he said the apex is in the normal location. The ventricle is not dilated, the ventricle is not receiving a large volume, if his finding is right. So heaving apex beat in and S4, diastolic dysfunction is there, and he has gone for systolic dysfunction also. That is the way I approach the case. Okay, but the oddity is in this. What are the, why the second sound is normally split and normal intensity? What do you expect the P2? In a patient who has ortho PND, who has left ventricular third sound, and probably it is heart failure with both diastolic as well as systolic dysfunction. What is the likely LA pressure in this case? It is definitely high. So the pulmonary post-capillary pressure is high. So you should have post-capillary pulmonary hypertension. So you should be careful. That is, the second sound is less likely to be perfectly normal in this case. Second, first sound. If there is a systolic dysfunction, the first sound may not be normal. So these are the areas where you are likely to be asked questions. You should be careful that these are the oddities. You can take anticipatory bail also. Say, sir, the second sound is normal, though I expected an accentuated P2. The first sound is normal. If you put it like that, that means you have thought about that. Okay, that's all what I want to contribute. Heaving apex beat S4, that is congruous. S3, you have to find an answer. There is no volume overload. There is no hyperdynamic circulation. That means there is a filling problem. It's either a restriction to filling with a rapid rise of the rapid filling rate. The S3 occurs in the rapid filling vein, end of the rapid filling vein. And if you look at the pressure tracing of constrict pericarditis or restricted cardiomyopathy or diastolic dysfunction, you find the rapid filling is sharp. So you can have a third sound in such situations. It need not indicate severe LV systolic dysfunction also. Okay, sir.
Only problem is that when the patient is having a constrictive physiology and has got a third heart sound or a pericardial knock, whatever it is, a fourth heart sound is very, very unusual.
Fourth sound unlikely.
Very unlikely, because that combination makes me very, very difficult to explain hemodynamically. Because if there is a third heart sound because of a restrictive process, because the heart is not a large restrictive process, then I would find it extremely difficult to explain a fourth heart sound.
Sir, that's a point which I want to highlight, that are you going for a restrictive physiology due to myocardium? Because we have, because of the PND, all those things, we were deviating from constrict pericarditis. So this is one situation where you can have a reasonably normal sized heart with third sound and fourth sound, if your findings are right. Okay. Well, there is no murmur. So we have ruled out valvular heart disease. Okay, so the pulmonary venous congestion is not due to a valvular heart disease. So we are coming to myocardial problem. Okay, the myocardial problem with a normal sized ventricle with these two sounds and a sharp wide descent. Okay.
I would still find it extreme, and even there is no RV leaf, nothing is there. Pericardium is quite, there is nothing there. So a significant tricuspid regurgitation also is a oddity, and also third and the fourth heart sounds coming together definitely is an oddity. I think we'll go to investigation and probably we'll find an explanation for that. Can we go to the next stage, ECG, X-ray, and further investigation?
Yes, sir.
Sir, shall I ask the doubt diagnosis? Their diagnosis and different diagnosis we have to ask.
Yes,
we have
yes,
contributed.
yes.
Protein group, what is your diagnosis? Or differential diagnosis, one or two?
And before also Coating group, what do you expect in the electrocardiogram? What do you expect in the electrocardiogram? Do you expect a LVH pattern?
No, sir. Here differential would be restricted cardiomyopathy.
Content team, please log out of one device. There are two devices. That is the reason you are getting the echo.
Do you think that this could be you can get an left atrial overload, left ventricular hypertrophy, right ventricular hypertrophy, right atrial overload?
Yes,
what can be there?
The probability of restrictive cardiomyopathy I will consider.
With the background of polyarthritis,
we can expect
what
biatrial
things
enlargement.
cross your mind? Polyarthritis with restrictive cardiomyopathy, you have to look into the differential diagnosis also. That is what, because we have two things. Try to correlate also. Was
yes.
Yes,
Yes,
sir.
so no, I was thinking
That's
that because of the easily palpable apex beat, which he said is a heaving apex beat, I thought the possibility of a constrictive pericarditis is very, very unlikely. I don't expect a heaving apex beat.
Constrict pericarditis is very, very low. I think that we cannot entertain because of symptoms, SO, heaving apex beat.
No, so that is very unlikely.
Very unlikely.
Yes.
But
if there is a S3, yeah.
So myocardium is abnormal. It is not dilated.
Yeah, myocardium is, but at the same time, there are some findings in the JVP which may tell you that there is an element of constriction, but it is not corroborated by the other physical findings.
That's right.
Okay.
The second step is to correlate with the joint disease also, whether you can or you cannot, or you have to take it as separate. Okay, go ahead.
So far, at the present juncture, I would think that we may have to take it separately because I am not able to completely explain both together. Okay. Now,
I think Misraya has to tell. Sir, Misraya was about to tell something.
Sir, one more thing. He said it is great to left parasternal heave, and there is no evidence of PAH. So what is the reason for left parasternal heave?
Yeah, so the
PH physical findings, he has not mentioned anything for us to tell about the parasternal heave. Sorry, anything to tell that there is a pulmonary arterial hypertension because second sound is normal, normal speed, everything is normal.
But there is evidence.
That's very difficult for the postgraduate. Bahel sir want to tell
So
something.
let's
Yes,
ECG. I would expect the patient to
yes.
have LVH, maybe pressure overload because of the evening apex beat. I would say the patient is having a left atrial overload also because of the paroxysmal nocturne dyspnea. Right atrial overload in view of the prominent JEP, I would think that the patient may be having a biatrial overload. That would right ventricle, I'm not certain. So left ventricle hypertrophy, right atrial and left atrial falling overload. That will be the ECG findings I expect in this patient. Okay, let us have
Bahel
this.
sir
Sorry, I
wanted to
didn't
tell something.
intervene because I knew the diagnosis. So I think the odd
Okay,
finding is
fine.
that the P2 should have been loud. So can we go to the investigations? We already crossed 8:30.
Yes, please.
So this,
Investigations.
yes, sir, EKG. This is 12 lead ECG showing left axis deviation with low voltage complexes in limb leads, with not in precordial leads.
When do you get that low voltage complex in limb leads with but not in chest leads?
We see in cardiac amyloidosis.
When there is generalized edema.
Yes, sir.
There is generalized edema, you
Yes,
get that. Okay, fine.
Usually we get in both.
No, amyloid is no. I disagree with you. Amyloid, there is a generalized low voltage complex, not specific for limb leads, but you can get even in the chest leads also. You can get low voltage complexes. Of course, more prominent will be in the limb leads. I agree, but there are other findings in the electrocardiogram. Please read the whole electrocardiogram.
There is a left axis deviation. There are QS pattern in B1 to V4 sinus rhythm.
So what does that mean? He has got QS pattern in V1, V2, V3, V4.
Inferior leads also.
Basically, you have sinus rhythm, left atrial abnormality pattern, and QRS abnormality, which indicate that there is a myocardial pathology. Am I right, sir?
Yes, I think there's something we have to think of the myocardial pathology, or whether I think definitely there is the ECG, the QRS complex in V1 to V4 is definitely abnormal.
And Dr. Misria's point, you have to look for AV blocks, arrhythmias. For certain restrictive cardiomyopathies, these are very useful. So are we getting any clue for any specific myocardial disease from this electrocardiogram? We are not getting any clues. That is my view.
Yeah.
But the clue is there is left atrial abnormality plus a QRS abnormality, which indicate that the myocardium is abnormal. Okay.
Low voltage complex also, very low voltage complex. Okay, go ahead.
Echocardiogram.
Sir, anything?
No, I think that's it. The low voltage in the limb leads in this patient is particularly prominent. So I think amyloid would be a possibility, and amyloid can explain the arthritis. So I think we have to keep our mind open. And just because the rheumatologist diagnosed seronegative rheumatoid arthritis, it's probably not true. It's probably the arthritis is due to the amyloid, and it is a well-described condition.
That's why I said that you have to try to correlate restrictive cardiomyopathy with joint symptoms. I gave the clue. I gave the clue that a restrictive cardiomyopathy with joint symptoms or a systemic problem, you have to ask for so many other things. I was asking them restrictive cardiomyopathy and try to correlate with joint symptoms.
Yes.
Okay.
And the
but the S4 is a very unusual phenomenon.
Yes.
Sir, S4 can occur, sir.
Not usual.
He is a hypertensive also.
But still, if there is a restrictive cardiomyopathy, usually S4 is not a common accompaniment of restrictive cardiomyopathy.
Sir,
usually.
Okay, sir. But I think it depends on the stage of the restrictive. Okay, fine. I think we have to think about that and read about that.
Yes.
Okay.
And by any X-ray test,
X-ray show the X-ray.
X-ray.
Unfortunately, the patient got discharged, and he got discharged recently only, and he didn't get the X-ray back. So we didn't not able to get it.
Okay. Now we'll see the echocardiogram. Let the Kottayam students read the echo.
There is some problem with the.
Just
wait a
you can restart it. It's okay.
Yeah, just restart the PowerPoint.
Yes.
Okay, meanwhile, discuss. Yes. Kotlin group, do you think, because because that I gave you a clue that correlate restrictive cardiomyopathy with joint symptom or systemic symptoms. So we have to go for specific disorders. But the point is, do you think the electrocardiogram is typical of any specific entity?
You
One
can
is-
consider amyloid. Amyloid can be.
Others can be.
But what are the
Amyloid-
typical findings of amyloid? That's what you, because it can go with anything. What are the typical things you should look for?
Amyloid is very
Okay,
often
there is a
associated.
disparity between the muscle mass in echocardiogram or total muscle mass versus the QRS potential.
Yes.
There is a basic disparity.
Voltage
There
mass
will be gross
dissociation.
myocardial mass, but the QRS electrocardiogram doesn't show that. Conduction problems. These are things which you have to look for. Okay, fine.
And also pseudo-infarction pattern is something which has been described in patients with amyloidosis, which we are seeing in this patient. And along with the low voltage complex pseudo-infarction pattern, I think amyloid as a differential or as an important diagnosis should be definitely considered.
Rahul, go to the echo, please.
Echo.
Yes, sir.
Echo, sir, in a 4-chamber view, we can see there is a gross 2D echo showing a gross biatrial enlargement, and also there is a thickened and sparkling of the interventricular septum, and even the interatrial septum appears to be thickened. And there is a LVH and probable pericardial effusion on the RA side. This pericardial effusion is also noted.
There is some pericardial effusion over the left ventricular side also, but not very gross, but it is there.
Yes.
And impaired contractility also.
Yeah, whether LV function is definitely impaired.
Yes.
You have all three features. You've got increased wall thickness, LV systolic dysfunction, as well as you've got restrictive features in the form of biatrial enlargement. So all
And
three.
also, and whenever there is a thickening of the interatrial septum, I think the most important diagnosis is amyloidosis. But here, only region which is not thickened is the valves. Valves are not very much thickened. Usually in amyloid, valve also can be significantly thickened.
Maybe the history was relatively short. Sir. It was not that long a history. Go to the next slide, please.
Yes.
Okay. What about the color Doppler? Is there what about the any regurgitation?
Just
okay,
restart.
at that point, we may ask you, that is about the echocardiogram features and all the features, then you are doing the echo. How will you confirm, or what is the solid point favoring you are doing echocardiogram?
Any advanced echo you would like to do?
I didn't use that word. You are doing the echocardiogram. What is the solid thing you look for?
You can do something advanced echo.
In a restrictive cardiomyopathy or a primary myocardial disease, which is the investigation which is going to be more useful in echocardiogram?
Strain.
What time group?
What strain?
Global longitudinal strain. In
What do you find? What will you find in global longitudinal strain?
There will be diffuse decrease in the strain, but the apex part will be relatively spared. So it will give an appearance of a cherry on top appearance.
The apex will
be sorry. Rahul, I can share the screen if you have a problem. I can share from my side.
No, sir, it's okay. I think it will be fine now.
Skip the echo and go to the one which doesn't have such heavy images. Skip the echo, go to the next slide. Yeah, next. Yeah, perfect. Next, please.
Shall we see the LV filling pattern? Just want to see the LV filling pattern. Cotton group, what will be the LV filling pattern in a patient with amyloidosis?
Restrictive.
What is the restrictive pattern? Can you explain?
Yes, sir. There will be diastolic dysfunction. Can be seen E by A will be high, and also
E by E prime will be increased.
In tissue Doppler, all the velocities will be low. It's 5 sign. We can set everything. The velocity will be less than 5 in tissue Doppler imaging.
And also, what will be the deceleration time? LV deceleration time? In this patient, what will happen to deceleration time?
The time is here is 108 millisecond. Dissolution time is decreased.
Yeah, it will be significantly decreased. Very often it is definitely less than about 130. So those are the features which will make you think that it is a restrictive physiology. And of course, the cherry on top appearance is very classical for amyloidosis. Yes, okay. Can we see the GLS also? Have you recorded?
Yes, sir. Yes, yes. These are the slides showing LV function and RV function. Both are compromised in this patient. Spectral tracking shows cherry on top appearance with severe impairment of longitudinal systolic contraction of -8% with apical sparing.
Basically, when you are asked about the diastolic dysfunction, you should talk like, sir, I expect grade 2, grade 3 diastolic dysfunction. And you should grade that rather than saying these things. Like looking at the echocardiogram, you should grade what is the grade of diastolic dysfunction. That is our aim. Not just saying there is diastolic dysfunction. You do these investigations or parameters and finally say has grade 3 diastolic dysfunction. You have to look into the IVC also to see what is happening. And this is the final answer for that. But you have to go through all those things. Because in this case, I'll be interested in those patterns. That is the diastolic parameters, the IVC Doppler, and the spectral tracking. The strain pattern and spectral tracking. These things you should read.
Yes.
Okay, you should be very clear about that. That question should be asked.
The Chandigarh group, how will you differentiate between grade 2 and grade 3 diastolic dysfunction?
Rahul, you have to answer that.
Yes, sir. So in grade 3, E by A ratio is more than 2:1.
Okay.
If for grade 2, if E by E prime more than 14, TR velocity more than 2.8 and LAVI more than 34. If out of these three, 2 are there, then it is grade 2 diastolic dysfunction.
How will you make out whether the diastolic dysfunction is reversible or not?
Well, sir.
How will you make out
pulmonary vein reversal? You didn't talk about the pulmonary vein reversal, hepatic vein flow patterns, and the question will be on constrictive pericarditis versus restricted cardiomyopathy. These things you should know. Okay,
and
at least you should read.
And how will you differentiate somebody who is having a grade 3 diastolic dysfunction? How will you make out whether it is reversible or not?
Valsalva we can consider.
Yeah.
We can consider doing Valsalva.
So what will happen? What will be the
reversible? It will.
Grade 4, it will remain the same. Grade 3, there will be improvement.
Yeah, it will be. There will be the grade 4 will practically remain the same. If it is grade 3, there can be an improvement in the diastolic function with the Valsalva manner. Okay, right? Yes. Okay, then now go.
Constrictive pericarditis also the questions will come. The annulus paradoxus, all those things, reversal, those things you should read because certain things you have to read. We'll give you only clues, which are the areas you have to read in these types of cases. Okay.
Okay. Now, any other investigation that you have done to confirm the diagnosis, and then what will be the management strategy?
Yes, sir. Next, we did a serum electrophoresis, which was normal in this patient. Followed by serum free light chain assay, which shows increase in kappa lambda, decrease in kappa lambda ratio with elevated lambda chains.
Oh.
In serum.
Fine.
Okay.
So we are trying to see what is the type of amyloid.
Yeah,
am I right? Okay.
Yeah. I think they're trying to analyze what is the type of amyloid. Tell us how will you make out whether which type of amyloid it is, and why it is important. Why it is important to make out what is the type of amyloid?
The treatment
strategies are different because for ATR type amyloid, directed therapy is available, but not so for ALM amyloidosis.
No, ALM amyloidosis is very much directed therapy. It's very similar to multiple myeloma.
I think basically you should read about amyloid in detail. All the investigation, the imaging modalities, and there is a question whether you should go beyond echo and these things. Certain types, especially the wild type, certain types, the further investigations may be needed. Whether the immunoglobulins are needed or not. There is a debate going on there. Whether you should go for immunoglobulins. Okay. So many things so many things you should know. I think we cannot teach you everything. We can give you areas where you have to read. There is diastolic function, amyloid in detail, because that will be asked. And newer therapies available, the drugs which have been available for, because certain myocardial diseases, there are targeted therapies. The two things will be amyloid and Anderson Fabry disease. These are the two areas which are taken for discussion during your examination. Because these two things have targeted therapies also. Okay.
Do you think that MRI is another investigation which can throw some light in these type of patients? And if it is yes, what is the reason?
Yes, sir.
The MRI? Yeah.
This is the 4-chamber cine of cardiac MRI showing biatrial enlargement with considerable LVH and pericardial effusion. In a second slide, it's showing global subendocardial late gadolinium enhancement, which is expected in amyloidosis.
And what is the other condition where you can get subendocardial gadolinium enhancement?
Most common condition.
Most common condition.
Subendocardial.
Ischemia.
No. Ischemia. Ischemia is always subendocardial most common.
Yes.
Go to the next.
But global is specific to amyloid.
Yeah. Global is more specific for amyloidosis. Yes.
Ischemia will be artery territory specific.
Yes.
That's a valid point.
You have to see whether it is patchy or not. Because Misri have raised sarcoid, all those things, though not during the clinical discussion. So certain things you should be very careful. Treatable myocardial diseases. And there are targeted therapies. So the aim of investigation will be to pick up those things.
Yes.
Okay, fine.
Yes. So in serum, yes, sir. Serum immunoglobulin in serum immunoglobulin assay, monoclonal lambda light chains protein were detected on serum immunofixation.
Next.
Then we followed it up with bone marrow biopsy, which suggested only normal hematopoietic elements proportionally represented with no increase in plasma cells. In bone marrow flow cytometry, revealed a normal number of plasma cells, but they were aberrant. Most of them were aberrant. On fish, it suggested TP53 deletion mutation. Yes.
The next.
Fat pad biopsy was negative for any amyloid deposition. So we did endomyocardial biopsy, which suggested deposition of focally and subendocardial location, extracellular hyaline material. The pale amorphous extracellular deposits are the amyloid, which showed apple green birefringence on polarized microscopy. Showed in second slide.
Fine.
What is the second slide show? I just could not understand. What is that? Apple green. What is that?
Actually, here they are appearing more yellowish, but I mean,
there is a yellowish one.
Yes, the yellowish part is the apple green part.
Yes, sir.
Okay, right. Okay. Is it a diagnostic?
Yeah.
Yes, sir. Yes,
almost.
Sir. Yes, sir.
Or is it a non-specific finding?
Diagnostic of amyloid.
By diagnostic, it suggests amyloid deposition in endomyocardial. On EMD,
okay.
Next.
So that is fairly convincing.
Yeah.
Okay, now coming to hemodynamics.
Yes, sir.
Okay.
On catheter. Yes, sir.
No.
Yes, sir.
Pressures RA, A20, V22, mean 17.
17 is mean.
Okay, A20, V22.
Yes.
Okay, almost same. Fine. RV, there was 62 but 23, but okay, there is significant RV hypertension. But you don't have the PA. Because you will be asked about the hemodynamics of restrictive cardiomyopathy versus congestive pericarditis. So be careful. This is not enough. And I'm not questioning the history.
You could have got at least the pulmonary arterial wedge pressure. If you have not done the left heart study, at least the pulmonary arterial wedge should be there. This is because you have to look at the pressures in all the 4 chambers during diastole to make a diagnosis whether it is constrictive pericarditis or restrictive cardiomyopathy. Why is the pulmonary arterial wedge was not done?
Yeah, ideally, a wedge should be done. I mean, this is an incomplete cath study. I agree.
So even if you don't
present intelligently, you should have presented. You should not have presented this data. You should have skipped this slide. Okay, because this is not enough. Okay, we don't get any information beyond your clinical judgments, but you can say that there is a problem here. Okay.
Okay.
RV diastolic is 23, RA mean is 70. We'll be grilled on that. Okay. Is it a usual finding? So be careful. Hemodynamics, you are not familiar. When you're presenting, it should be complete. You could have skipped this slide so that you could have avoided trouble. Because that's the only thing which is available here. CS hypertension. Okay, systemic hypertension. Yes, elevated right atrial pressure. And right ventricular systolic pressure is elevated. Right ventricular diastolic pressure is also elevated. There is a disparity between the RV diastolic pressure and RA pressure. This is the way we critically analyze this thing. And as we said earlier, you should have looked into the PA pressure. You have to PA diastolic pressure, you should have looked into at least, and the pulmonary artery bed pressure. Okay. Fine.
Actually, the aim was just to do endomyocardial biopsy. So we went in straight to the
fine.
biopsy sheet. So from RA to RV biopsy and out. So that is what was actually done.
Oh, fine, fine.
But
So it was not intended for a postgraduate discussion. That's what sir says. Fine, accepted.
And also, the A wave is, I just want to be clear about RA means A wave 20, B wave 22, and mean 17. Is that the pattern, or 20 is the mean pressure? 22
No,
is
17 is the mean
pressure.
pressure. 17 is the mean.
17 is the mean
A
pressure.
is 20.
Okay. And the 20 is the A wave, and the 22 is the B wave.
There is a reverse gradient. There is a problem. And there'll be a question on reverse gradient also. Okay.
Are we diastolic? Of course. But of course, in pressure tracing, 1 millimeter, 2 millimeter difference may not be very significant.
But here it is 17 and 23, sir. Anyway, sir,
17 is
sir has said it was not a meticulous hemodynamic tracing. They were doing the endomyocardial biopsy, so they just took a catheter trace. That's all.
17 is
It was
mean.
not.
So 23 or 23 should go with the A wave. So A wave is 20. But all right, okay. But anyhow, if there was a pulmonary artery pressure as well as pulmonary artery beds, I think the hemodynamic discussion of the constrictive pericarditis versus the restrictive cardiomyopathy would have been more fruitful. Okay, right, yes. Now regarding the management, what did you do to the patient? Did you do something, or you just treated heart failure?
Yes, this is the immunofluorescence study, which was negative for kappa, but strongly positive for lambda in subendocardial location. Second slide, which is lighted up with green. So it confirms the pathological diagnosis of AL amyloidosis.
Just go to the treatment. I think we are short of time. So
yes, treatment. The patient was started on DARA BCD regime, daratumumab along with bortezomib and cyclophosphamide, and GDMT for heart failure.
And it has just been started, so we don't know how he's going to respond to this. So he's just received the first cycle right now.
You have to wait for some time.
Just want to ask you, when in the cardiac amyloid, the joint involvement, how frequent it is? Yes, but the acute joint involvement, can we think that the joint involvement is independent of the process, or is it the same process?
So the joint involvement is not uncommon in cardiac amyloidosis. So joint involvement is very well described, and probably the onset of the joint involvement was almost a little, maybe 2 months prior to the onset of heart failure.
Oh yeah, 1.5 months.
Amyloid related. Yeah, I just would like to show 1 or 2 slides. Can you just stop the screen sharing?
Yes.
Just extra cardiac manifestations of amyloid. It'll just take me
I think what the student has to do is, once you have diagnosed this thing, you have to go back.
Oh, yes.
You have to go back for the reflex in amyloid. What are the other things? High risk cases, all those things, fine. Carpal tunnel, all those things you have to look into.
Yes. So some of the manifestations, I'll just show. This is not this patient, another patient. This is typical raccoon's eye. So because the capillaries are fragile, there's bleeding and there is some amyloid deposition around the eyes. So that results in a raccoon's eye. So one of the manifestations we saw in this patient is arthritis. The other is raccoon's eye. Then dystrophic nails can occur in amyloid. This is another manifestation. And then there is macroglossia. We can clearly see the dental implant. So these are some of the manifestations of extracardiac manifestation amyloid. The other thing is any patient with heart failure and carpal tunnel syndrome, one must suspect amyloidosis.
Carpal tunnel, nerve entrapment, carpal tunnel, and look at the tongue. These are simple common things. We should not forget that. Nerve entrapment, carpal tunnel.
Tongue is one situation where you can get a definite clue. I think tongue definitely is something which you should have. Going back, you should have looked at the tongue and made a comment about that.
Dr. Anuradha Lala has joined. Sir, Dr. Anuradha Lala has joined for the discussion, so we can have a few minutes. Because already we are reaching 9 o'clock. So
okay, right. I think it was a very challenging case, very unusual presentation, and also few findings still we are not able to explain. The presence of third and the fourth axon coming together in a patient with amyloid is very a bit unusual, and also the P2 is absolutely normal with normal split, but also is very unusual. So, but otherwise it's a wonderful case, fully investigated, and it's something which we should remember that when a patient is presenting with feature suggestive or restriction, an amyloid should be always thought of, and which is a treatable condition.
My side, the approach should have been in two ways. One, two sets of symptoms, try to correlate that. Don't be taken away by the cardiac symptom alone. So both were important. So cardiac and the joint symptom try to be correlate. Second thing, when you present the JBP and basic things are the clues. When we say sharp wide vision, you have very limited things. Sharp vision, you look at the V wave. If the V wave is normal, sharp wide vision, the things is a restriction to filling, either because of a pericardium or a myocardium. And when you found that there is a symptom of paroxysmal nocturnal dyspnea, heaving effectively, for practical purposes, we go away from pericardium. And when you have come to myocardium, you have a normal sized heart without ventricular volume overload, and you have a third sound and fourth sound. So myocardium is abnormal. So when there is a myocardial abnormality, it cannot be explained by hypertension alone. Earlier, we took Madam's presentation as heart failure staging as well as preserved. All those things should be considered in this thing when you are discussing these things. So we have gone for a myocardial disease, and myocardial disease where the ventricle is not dilated, you think in terms of a restrictive phenomenon. No murmurs, so restrictive. When there is a restrictive physiology, restrictive myocardial disease, look for systemic problem to differentiate what is the type of disease. That is an approach for this case clinically.
thank you, sir. Shall we move to the discussion? Welcome, Dr. Anu Lala, to the forum.
Thank you for having me.
Yeah. So, what is the time there?
I just dropped my kids off to Vivekanand Vidyapeeth School, so I'm like fully Indian submerged. So we just did prayer, and I came now. So it's 10:30 in the morning.
So we enjoyed your presentation. So what do you think? What will be the future therapy in heart failure? So will the newer anti-diabetic drugs will be an integral part of the therapy, or what is your take on that?
Yeah, again, just thank you for having me. I missed being at HFAI this year, but hopefully next year in Ahmedabad. I'm very, very excited about the direction that we're moving in, which is more of a focus on cardio-kidney metabolic health than it is just isolated heart failure as an end of the spectrum of disease. Because most people hear heart failure and they feel like life is over. And I think we are recognizing how much it exists across the spectrum of health for our patients. And I think particularly South Asians are really, really afflicted by derangements in cardio-kidney metabolic health. And I think that the incretin-based therapies, the GLP-1 receptor agonists, the GIP agonists, are going to be a major, major player in how we treat our patients, both upstream and downstream of the diagnosis. I also, Dr. Vijay Chopra and I were sitting next to each other at a meeting in Madrid just 2 days back, where we're launching the biggest heart failure clinical trial ever, which is going to be called Prevent HF. And that's going to be the combination of an SGLT2 inhibitor with a mineralocorticoid, not a mineralocorticoid receptor antagonist, but rather an aldosterone synthase inhibitor. So it'll be in combination with dapagliflozin, and it's going to be given to over 11,000 patients with a history of diabetes, pre-existing coronary disease, and elevated blood pressure, all with the intention of looking at the primary outcome of incident heart failure. So I think our field is moving more and more along the lines of trying to treat whole body health, which actually I think Indians are much better at than Americans, quite frankly, because we're so siloed. And so I'm very encouraged by the direction that the field is taking in general.
Thank you. Abraham, any comments?
Yeah, Dr. Anu, wonderful talk. My question to you is that post-transplant patients, can you call them stage B heart failure? And I've been trying to push our transplant team to give all of them statins, GLP-1 and SGLT2. Am I wrong in my approach?
No, I love your approach, Dr. Uman. I'm not surprised because we saw so much eye to eye when we met. I don't know if I think we can call it stage B heart failure, but I just submitted a scientific, it would be wonderful to do this together as communities and societies, HFAI, or a broader population with HFSA. I just submitted the scientific statement with the American Society of Preventative Cardiology and the Heart Failure Society of America along the lines of the talk that I presented to you all, which is really, we can use this staging because it's been around for so long and people have now accepted it. But really to consider, just as you said, Dr. Uman, these patients again are in the cycle where we have to prevent them from going on to developing worsening heart disease. So I completely agree with you. I have every one of my transplant patients on a GLP-1 receptor agonist, SGLT2 inhibitor, statins, of course, with an LDL goal less than 100. I'm managing their hypertension with ACE-ARB ARNI. So I'm really treating them like you referred to, like stage B, but I don't call it as such.
Ajay Bahal, Sudev Umar sir, Manjuran sir, any comments or?
No, I think it is a very enlightening talk, wonderful, and she has covered everything in heart failure and has opened a new line of thought process where the patients with heart failure can be more effectively treated.
The sir is muted.
Dr. Ajay Bahal, you are muted, sir.
Yeah. No, thank you. That was a wonderful talk.
Basically,
Thank you.
yeah. Basically, the talk was wonderful, and we could take that discussion to our case discussion also, because that staging of heart failure, how to go ahead with that, that was really wonderful because it was good for the students also.
Well, thank you so much. I'm sorry I wasn't able to deliver it live.
Yeah, that's fine. That is fine. Dr. Ajay Bahal, please go ahead.
No, I said wonderful talk. Thank you so much.
So thank you, Anu, for joining, and
my pleasure.
we had a very great case presentation, very great discussion. We also learned a lot hearing the master teachers discussing the case. So thank you, everyone, and we had a good presentation from very well worked up case from PGH Chandigarh. Thanks to
I saw that.
Dr.
I saw that. That was excellent. Excellent.
So Dr. Ajay Bahal and the team, and also thanks to Kottayam Medical College, Dr. Misri and the team from Kottayam. Over to Arun for the vote of thanks. Thank you.
Thanks
Thank
to
you, sir.
Dr. Bahar because it created nostalgia. I am a PGI student. So to discuss a case from PGI, I really enjoyed it.
And
I
even
think
more
one
greater
great thing is
nostalgia for me, because both of them are my teachers. Dr. Manjuran and Dr. Sudhirkumar are my teachers, and probably the reason why I became a cardiologist.
And I think the one wonderful thing about the case is that it is completely worked up. I think it was is how a case could be well worked up, and also and the management also is in the correct lines. Great. I think congratulate the PGI for such a wonderful case.
Arun, please go ahead. We are already
Thank you, sir.
exceeded
Thank you,
5
sir.
minutes.
Yeah, we've had a fabulous start to the year. I must thank Dr. Anuradha for taking her time out, despite the difference in time zones as well, and fabulous talk. And thank you for joining as well, despite your busy schedule. And I must thank the examiners, Dr. Manjuran sir, Dr. Sudhir Kumar, Dr. Ajay Bahel, and Dr. Arhanathun Misria for the excellent discussion. And a special thanks to the PGI team, Dr. Rahul Bundela, for the well worked up case and the excellent presentation. Must mention that the residents from Kottayam Medical College were excellent in the discussion. Dr. Vivek, Dr. Sri Gopal, and Dr. Manjunath very well discussed as well. We've had a fabulous attendance to start off this year's programs. I think we had 146 plus attendees, and it was fabulous to start off the year. This session is now gone to the fifth year rather. And great thanks to to Chopra sir, Dr. Abraham Oman, Dr. Venugopal sir, and Dr. Harikrishnan sir for the enthusiasm and for taking this from step to step forward, and Dr. Sarjan and everybody who was working behind to get the things going. Sumita from Heart Failure Association of India. We've had Sun Pharma and Corona's team in Netcast who've done their bit to ensure that this is going on at a global level now. Must thank the Heart Failure Society of America for agreeing to partake with us in this year's program as well. And we'll have this session going on monthly, and the next session will be on the second Saturday of next month. And we'll have another set of teams, and the roles will reverse. Usually the student panel becomes the presenter, and the other way around. But nevertheless, we've got exams as well coming up next month for a set of teams. So we'll see how that works out for next month. Thank you all for joining and for staying back so late in the evening back in India. And sorry to keep you waiting, ma'am, in the midst of a good Saturday probably there.
No, it's my honor.
All right. So
thank you, Arun, thank you, Hari, and thank you, Oman, and all the others in the Heart Failure Association of India for inviting us to be a part of this program, and also tell something to students by means of which they can improve their performance in the examination. And I think we had a wonderful session, wonderful case, and wonderful discussion, and it was actually an explosion of knowledge in all directions. Thank you.
Thank you, sir, and good night.
Good night.
Thank you, sir.
Thank you, sir.